implementation of NDP-9, as well as measuring progress we make towards poverty reduction and the attainment of more long-term development objectives such as the SDGs. Some of the groundbreaking findings in this survey concerning maternal, newborn, and child health are sure to have the wide-ranging policy implications, including persistent high maternal mortality rate in Somalia can be attributed to a low uptake of antenatal care, postnatal care, and low number of delivery and health facilities or with skilled healthcare providers. 2, Somali mothers were able to present health cards for only 4% of children aged 12 to 23 months, and just 10% of babies delivered live at their weight reported, and 9% of which were infants with low birth weight less than 2.5 kg. These findings are more show the urgent need to adjust our planning and programming in these vital areas across the country. As we say in Somali, literal means with information we can make better decisions. Somalia has come a long way in terms of data collection, number crunching, and statistical analysis. So this report will be the first of its kind in our history when we look at the data produced in this 460-page report. We now, in addition to these efforts, we now have a statistical act passed by the Parliament to form a Bureau of Statistics, which will also help us further put together other surveys. And as you all know, it's also vital for us to support the formation and the progress of this important institution to ensure that Somalis have access to better information, better plans, and better lives as a result. So I urge you all to support that institution when it's up and running in the next few weeks. Finally, I would like to acknowledge the important role is undertaken by the Director of the National Statistics, the Minister of Planning, in collaboration with the Minister of Health and Federal Member State Ministries of Planning and Health to complete this report. Additionally, I would like to express a sincere appreciation to the crucial role played by the UNFPA in providing a high level of technical expertise, resource mobilization, and management support during the process of performing this important exercise. It's also worth mentioning that the support of the donor partners was instrumental for the implementation of the SHDS. Our thanks go to all partners who ensured Somali women and men were in the forefront and able to develop their capacity in many ways. Our sincere appreciation goes to the UK Department for International Development, DFID, the government of Sweden, the government of Finland, the government of Italy, the Italian Agency for Development Cooperation, and the Swiss Agency for Development and Cooperation for the generous contributions. Thank you very much. Last but not least, I'd like to express my gratitude to the UNFPA country representative, Mr. Andrews Thompson, for his support, and his deputy, Mr. Walter Philho, and the entire UNFPA staff. More specifically, to Mariam Al, the Population and Development Specialist and Head of the Population and Development Unit, UNFPA Somalia, for their dedication to Somalis and devotion and patience in steering this mission. Thank you all very much.
Hi, thank you very much, Ambassador Gamal, Minister of Planning, Investment and Economic Development, for those thoughtful words, and also for your contribution in terms of successfully implementation of the SHDS. And now, without further ado, let me welcome Honorable Fawzia Abikar, Noor, Minister of Health, Federal Government of Somalia, to say her remarks of this special event. Welcome, Dr. Fawzia Abikar.
Mr. Jamal, a very good afternoon to all of you. It's great to see you in large number, although we cannot be sitting in, we are not sitting in the same room, but we can communicate, thanks God. So I would first like to start off by thanking and welcoming all participants who are here with us today during this historic launch of the Somali Health and Demographic Survey. It has been a long and challenging road. I would like to express my gratitude to all who took part in this survey at all levels. Due to the current ongoing pandemic, we made the collective decision to launch the results in this manner. But the anticipation and participation by all of you is a testament to the importance of Somali Health and Demographic Survey. I would like to particularly extend my gratitude to the enumerators who carried out the field work, to the leadership and technical teams from the Ministries of Health and Planning at both federal and state levels, UNFPA Somalia, who supported the project, and the donors who have stood firmly by Somalia and continue to support our quest to the stability and sustainability. A big thanks goes to all the donors who supported this process. Without your support, we would not have come this far. It's also worth mentioning that to date, in most countries, such an exercise is led by the DHS program, as we planned during our familiarization tour to Rwanda. Yet in Somalia, this large undertaking was led by Somalis. This was especially possible thanks to the support lent to us by the UNFPA Somalia office, and specifically the Population and Development Unit. We thank them one by one and their leadership. Special gratitude to Mariam Ali. Somalia is a state which is still recovering from the traumas of war. The health system and institutions of the country need to be strengthened, and Somali Health and Demographic Survey is a model example of how our partners and donors can help us achieve our vision. Post the challenge of the government, this has been the biggest statistical exercise conducted in Somalia. We view this as a significant milestone achievement, which the Somali people should be proud of and be willing to build on. This was a survey conducted by the Somali government, and we are grateful to our partners for the capacity given to the Somalis. It's worth mentioning that the large majority of the enumerators who conducted the fieldwork were young Somali women. We are proud of these young women who were at the front line of the data collection process. The data which Somali Health and Demographic Survey provide us show a clear, accurate, and up-to-date picture of the current situation in Somalia. This data will enable the Somali government to effectively plan, make policy, and evaluate the progress made, especially in sector development plans and goals. The data generated shows the need and importance for the Somali government and all relevant end users, as well as donors and partners, to coordinate and jointly continue working to better the life of the Somali people. The data gives us crucial data. It gives us a crucial on indicators such as the maternal mortality rate, the child mortality, the vaccination coverage, the rate of the FGM, female genital mutilation or cutting, which are part of some of the key components of the primary health care. It will also allow us to monitor the health situation in different parts of Somalia and allocate resources more efficiently to respond to the needs on the ground. The generation of the data is the first step of money. It's vital that we now all come together and use this information to act and change the current realities of the health of the Somali women, children, and youth. Thank you so much.
Thank you very much, Honorable Dr. Fawzia Abikar Noor, for that statement and opening remarks, along with Ambassador Gamal Hassan. Indeed, you have echoed very important key message there that it's a capital mistake to conceive or conceptualize without having a robust and accurate data for your development programs. So we are hoping that with this data, just to see that we have a number of participants, and we have over 200 participants joining us. And we also streaming live on YouTube. We also have our sister UN partners, UNDP, UNICEF, IOM, and others who are joining us, as well as key government and UNSOM, as well as key government partners, ministries of education, agriculture, and also other ministries are also joining us. So thank you very much indeed. Indeed, everyone is very eager to receiving this information and data to be able to use it for policy planning and also monitoring developmental programs, namely SDGs as well as ICP. So now we've, as you know, UN family is a very, very large family, and they have been very much instrumental to supporting, to making and shaping the process of the SDGs. So on behalf of the UN family, let me invite Anders Thompson, UNFPA representative Somalia, who's been very much tirelessly has been working to make his socks off to make sure that we make sure that this project is finalized or complete, and then we have the final product to deliver today. So let me welcome Anders Thompson to say his remarks on behalf of UN. Welcome, Anders.
Thank you very much, Osman. Honorable Minister Jamal, thank you for being here with us. Thank you for your leadership. Honorable Minister Fauzia, thank you for being here. Thank you for your leadership. And thanks to all the donors, particularly the 5 donors who have supported this: UK, Sweden, Finland, Switzerland, Italy, and those 5 donors who have been here with us on this whole journey. Now, let me just start by saying that we had hoped to have this big launch, of course, in the hangar. And I know that the applause from the audience when the speeches are given are a little bit more dramatic in the hangar, but I'm sure we can all imagine the welcoming applause for this tremendous amount of work that has been done, led by the Somali government. Adam Ademola, the DSRSG, was supposed to be here today. Unfortunately, he could not join, and he asked me to deliver his remarks on behalf of the United Nations family in Somalia, which I will now do. What he's wanted me to say is the following. Good afternoon, distinguished government representatives, members of the donor community, fellow UN colleagues, and everyone who has taken the time to join us today. The United Nations was created 75 years ago to maintain international peace and security, encourage cooperation among nations, and to promote social progress, better living standards, and human rights. Today, the mission of the United Nations is more relevant than ever. Somalia and the world are facing unprecedented challenges that must be addressed in the global community. I'm encouraged that despite all the struggles, there is hope. Today, the Somali government is equipping us with rich information presented in the Somali Health and Demographic Survey report that will serve as a powerful resource for addressing the needs of the Somali population, in particular women and girls. The report captures the voices of Somali women and men who speak on behalf of their communities, neighbors, loved ones, and their children. The diverse information that they have shared with us covers children and maternal health, mortality, housing characteristics, chronic diseases, education, wealth levels, health expenditure, female genital mutilation, and other forms of gender-based violence, and more. Now it is our job to listen to those voices and translate the numbers we see in the report to understand the needs of Somalis, leverage on windows of opportunities we see, and package all this into solutions and action. The SHDS offers some very compelling information about Somalis from urban, rural, and nomadic households. Most notably, while there are areas that need, the report shows a number of sectors. For instance, Somalis have witnessed a drop in maternal mortality from 732 of 100,000 live births in 2015 to 692 today. This is encouraging. It means that something, no matter how challenging, is working. Our job now, as the UN, international community, and decision makers, is to support the government to help Somalis continue building their systems in health planning, data collection, social mobilization for change in behavior, and so on, to ensure that progress continues. Of course, none of this progress will take place overnight, but with the rich information that we have from the SHDS, we can continue taking steps towards improving the lives of Somalia's people. It gives me great pleasure to acknowledge the monumental work carried out by the federal government of Somalia together with the federal member states. With UNFPA Somalia by their side at every stage of the survey, and with support from their key donors, they have done a commendable job in collecting crucial information that can be used by us all of us. At the heart of all this work are the teams of interviewers who left no stone unturned to reach households they were assigned, as well as the Somalis who opened their doors and welcomed the teams. Without you all, we would not have been able to complete the survey. I'm looking forward to seeing the findings from the survey and the path that has been created in terms of mapping and data collection being used to attain the Sustainable Development Goals. I also look forward to seeing these resources being used to roll out efficient and effective emergency response plans, including those to address the ongoing COVID-19 pandemic and other recurrent natural and man-made challenges that Somalis face. Most importantly for me personally, it provides the needed basis for the UN system to craft a robust United Nations cooperation framework that will respond meaningfully and purposefully to the Somali government's priorities espoused in the National Development Plan 9. On behalf of the UN family, I would like to assure you of the United Nations commitment to support Somalis in helping reduce inequalities highlighted in the contrasting numbers presented. I look forward to a brighter future together where we can work hand in hand, guided by our shared values of peace, dignity, and equality on a healthy planet. Thank you, and Ramadan Kareem to all. So this is where I imagine the applause for the remarks by Adam Adamola, our leader in the UN, the DSRSG. And I know this is followed by a few remarks by the UNFPA representative. I will, and for the sake of time, concede the floor to the next speaker and just add that I have been really honored to work with the Ministry of Planning, the Ministry of Health, with the support of our 5 donors over the past 3 years on this. And I also here want to mention one particular person who is with us today online, who had a big role in this, and that is my predecessor, Mr. Nikolai Botev, who started this entire process and who believed this could be done in Somalia when nobody else believed it, even DHS in Washington. And had it not been for him planting the seeds, I could not be here today to take credit.
Thank you very much indeed, Anders, for delivering that message on behalf of UN family. As you said, we have a number of UN agencies who are present today, and FAO is the latest one that joined along with UNICEF, UNDP, UNSUM, and as well as IOM and UN, federal government, as well as international NGOs who joined to witness and bear witness to the official launch of the Somali Health and Welfare Survey. Looking forward to the data to be able to use it for developmental programs, as has been echoed by both ministers as well as the UN family. So thank you very much indeed, Anders. Now, without further ado, let me move on to the next item on the agenda, which we have Somalia partners perspective. Obviously, without the lifeline and the funding of our Somalia partners, it would have been frankly impossible to implement this survey. So let me first welcome Eric Lundberg, the ambassador of Finland to Somalia, Uganda, and also permanent representative to UNEP and UNHABITAT, to say his remarks. Welcome, Eric Lundberg.
Thank you very much. I hope that you can hear me. Good afternoon, everyone. Honorable ministers, Ambassador Gamal Hassan, and Dr. Faviza Abikar Noor, UN Resident Coordinator and Humanitarian Coordinator for Somalia, Mr. Abdam Abdelmoula, UNFPA representatives for Somalia, Mr. Anders Thompson, representatives of donor partners, Director Generals, experts, and advisors of the Somali Health and Demographic Survey. Ladies and gentlemen, as a longtime partner to Somalia and a co-chair of the UNFPA country program, I extend the warmest congratulations to the government of Somalia, as well as to the UNFPA for the enormous work that has been done together. Congratulations to all who have played a part in making this important survey possible. The Somali Health and Demographic Survey will now provide the reliable data that the government needs in order to implement inclusive policies that will improve the health and well-being of the population. Data is indeed crucial for planning and implementing policies that will promote equity and equality. It also supports the international partners in their planning and response to the needs of the Somali people across the country, of all ages and both sexes. Accurate health information plays a critical role in developing successful programs and strategies targeted for effective response to maternal and child mortality and morbidity. We hope the Somali Health and Demographic Survey will assist the government and its partners to reach the ICPD goal of reducing the overall maternal mortality rate across the country by no less than 25% by 2030. I hope that this survey will be widely read, studied, and analyzed to maximize its potential impact. Personally, I know I'm looking forward to reading it. Thank you very much. Mahasanid and Ramadan Kareem.
Thank you very much, Ambassador Eric Lundberg, for those key words and key messages. Obviously, yes, as you mentioned, data is very, very much important to be able to gauge our development progress, as well as monitoring and evaluation. It will also contribute to the governance and accountability of our Somali institutions alike. So let me, without further ado, let me also welcome Honorable Ben Fender to the current Ambassador of Great Britain and Northern Ireland to Somalia, to say his remark.
Thank you very much indeed. Minister Jamal, Minister Fazia, Anders, thank you so much for your invitation today. I'd just like to make three brief points, really. The first is to say this is a simply extraordinary achievement. It's hard to imagine any other survey that's been done in such complicated conditions, an environment of conflict with very poor infrastructure, nomadic populations. Many people, as Anders said that this survey couldn't be done, and we have done it. And not only done it, but also done it in a way of which all those involved can be really proud, with some truly innovative uses of digital information collection, uses of satellite imagery. It's an extraordinary thing to have done. And from a UK's perspective, you know, we think everyone involved should be really proud of it. and we're absolutely delighted to have invested, what is it, $6 million over 5 years in this project. Second point, this is extraordinarily important, this data. Again, it's hard to imagine a survey that has produced so much data on a country where there is so little, and where donors, partners, government are so thirsty for really accurate information to guide what they're doing. I know from our perspective as a donor, there is barely any aspect of our development assistance here in Somalia that won't be touched and informed in some way by the information that has come out of this survey. So if it helps to coordinate and direct the enormous amount of development partner activity in Somalia and the efforts of government at every level, it will have been truly worthwhile. And I think there's a bigger point too, a really strategic point, which is this, and it's one that informs the UK's development policy across the world. Every country pretty well goes through a demographic transition at some point. And that transition can either unlock growth for the future, or it can really hold back a country. The countries that know where their population bulge is, that invest in education and health when that population bulge is young, that invest in job creation and in enhancing the skills of the workforce and in taxing the workforce and creating infrastructure when that population is of working age. Those countries can really use demography as a springboard to prosperity and stability. And the countries that struggle to invest in their human capital in the right way, that struggle to invest in nutrition and education and healthcare at the right time in the right place, can find that demography holds them back. So even more than the way in which this survey should inform individual development programs, I really hope it will inform Somalia's national strategy, so that actually we can take Somalia's greatest asset, its people, and turn them into an engine of future growth and prosperity. And my third point is simply that these are not just dry statistics. This survey must be a call for action. Some of the things that this survey finds should really motivate us to change the world that we find. To find, that 90% of rural households, aren't treating their water at all. To have a maternal mortality rate that may have improved, but is still 692. That only 9% of married women are in any form of employment. Page after page after page of really extraordinary statistics, which I think more than anything should get us to redouble our effort and target it on making a real change to those people. So let me finish there, but just to say again, from the UK's perspective, how proud we are to be involved in this project, how in awe and admiration we are of all of those across the FGS, the enumerators, the field teams, UNFPA, and everyone who's been involved in this, and how the final point is just really that the survey is a great achievement, but what will really be valuable in the long run is how far we can act on it and implement it. And I would encourage all stakeholders and partners really to interrogate and use this data, because this is not just dry statistics done for the sake of it. It is done so that we can all make a better future for Somalia. So thank you again.
Thank you very much, Ambassador Brenda, for you don't want this report to end up on the shelves and become a dry statistics, as you said. And as you know, numbers are very much important and they tell us stories, but it depends on us, all of us, to give the clear, convincing voice and to be able to use it for development progress. For your key message there and also your contribution to the implementation of the SDGs. Let me also, while we're here, to extend our gratitude on behalf of UNFPA and also Somali government, the government of Sweden, who also contributed handsomely, the government of Italy, the Italian Agency for Development Cooperation, and also Swiss Agency for Development Cooperation. They've all contributed, just as the British government as well as the Finnish government have contributed. So we also want to mention that. So thank you all for your key support, and hopefully you will continue in the aftermath to be able to use that data to be able to develop Somali systems. Thank you. So let me, so that's for as far as the key notes, speaks, and also the key remarks are there. But let me also pause here to share with the audience the Somali Health and Demographic Survey, a short video depicting on the different stages and different paths, and also the key, the trials and tribulations, if you like, and also the challenges, successes, the different population domains. So please let me call upon Stephanie to share that video with the audience, just to give the context. Thank you.
In 2018, the Somali federal government and member states took a large leap forward by undertaking a survey to find out more about the health and lives of Somali women and children. My name is Mikaltuma Ibrahim. I work with the UNFPA as a member of the Somali Health and Demographic Survey technical team. For the first time in the history of Somalia, a nationwide survey of this scale has been conducted. For the survey, more than 300 Somalis interviewed over 100,000 households across the country to ask questions about the health of women and children. More than 3/4 of these interviewers were women, almost all of whom had backgrounds in health. They walked through rough terrain with no roads, carrying with them scales to measure the weight and height of women and children. They climbed hills and braved the scorching Somali sun to interview a diverse representation of the population, the settled population and the nomads who had hardly been reached before.
waxaan lugaynay in la eg tusaale 3 kiiloomitir iyadoo ay jirtay qorax fara badan dabayl geedo aysan qof bini aadam u masaamaxaynin inuu ku lugeeyo meeshaas haddana culays uu noo dheeraa oo ahayd inaan wadana miisaamo oon ugu talagalnay inaan ku cabirno dadka deegaanka markaanu u soconay waxay ahayd sidoo kale caqabad aad u fara badan.
Without these brave interviewers, this survey would not have been possible. The findings will result in a child or mother receiving better services in health, nutrition, or some other form that will improve their lives.
So thank you very much, Stephanie, for sharing that video. Apologies for the initial clip, which had no voice, but eventually we got it right. So apologies for that technical hitch again. So that just gives you just basically a snapshot of what has transpired on the ground. People have actually made a quite significant distance to be able to capture this data, to be able to collect it. People have crossed rivers, mountains, and different trains, and even some people were quite unfortunate to be in the midst of a flood that has occurred during the survey. So very much appreciation for all the data collectors and all the teams that has actually made this possible, and also the UNFPA technical teams who were on standby, and also the Somali government who have been providing the leadership, the ministries of health and planning, and so forth. So now let us, the moments that you'll be all waiting for, let us share with you the key findings from the Somali Health and Demographic Survey. Let us unveil this momentous data and to share it with the team. So before we do that, let me welcome DG Abdurrahman Dahir, who is currently the DG, Director of the National Statistics of Federal Government of Somalia, to start, and then we will have Felix and Abdunur, who will provide us with the key data. Welcome, DG Abdurrahman.
Thank you all. Thank you, Osman. It's our pleasure to present the findings of Somali Health and Demographic Survey. This is a very important survey. It is the first time we conducted Somali Health DHS in Somalia, which fill the data gap. There was a lot of data gaps in the country, exist in the country. But this survey will fill the statistical data gap and will also use the results with the National Development Plan to measure the performance or the progress of the NDB 9, as well as the end line of the previous NDB 8. So as I said, this after the successful implementation of the PES, we decided to conduct this survey. It took 3.5 years. We started in 2017, the design and the preparations of the survey. And also today we are launching the survey. We have a lot of statistical data. As I said, we will fill the data gap. So I would like to thank the UNFPA team and the donors who contributed a lot, who encouraged us to conduct jointly with this survey. This is a very important survey, and it's the first time, as I said, in conducting Somalia. So I will try to hand over the full presentation to my team, but I would like to share my gratitude to my team, to the minister who gave us his leadership to full successful of the Somali Health and Demographic Survey. I would like to also thank the UNFPA technical team who was working closely with my team, also building the capacity of these Somali statistical departments, Somali statisticians. As you know, we will have the Somali National Bureau of Statistics. We will coordinate all the statistical system of the Somalia. So the findings of the Somali High Frequency Survey, my team, Mohammed Abdunur, followed by the Felix, will present. I would like to welcome them.
Thank you very much, Mr. Dichi. My name is Mohammed Abdunur. I'm going to take you through the presentation. I'm going to take the first part of the presentation. My colleague Felix Mulama will continue the rest. And let me start with the contents. And the report has several chapters. As you can see here, we have 12 chapters, starting the household population and housing characteristics, followed by respondents' characteristics and marriage, fertility, and birth spacing, and maternal health, child nutrition, HIV/AIDS and STI infections, women's empowerment, gender-based violence, and female genital mutilation, FGM, female circumcision. We have also chronic diseases. And finally, we have adult and maternal mortality. The sample design of this survey was for the rural and urban developed in using satellite imagery and delineated into ES of 50 to 149 households. And for the nomadic, and developed the frame using a list of the temporary nomadic settlements obtained from the nomadic link workers. For the sample selection, the survey targeted 100,000 households for the MMR and 1,600,000 for the main survey. The sample selection was based on a three-stage stratification, where the first stage was selecting the ES, and 10 ES were selected by stratum per region using probability proportion to size. The second stage, 30 households were selected from each of the 10 ES. And the third stage, women aged 15 to 49 and children under 5 were selected for measurement and for interview for ever married and never married women. The overall response rate for this survey was 99.3% for the households and 91.8% for individual questionnaires. To the questionnaires, the survey used 4 questionnaires. First was MMR questionnaire, second was a household questionnaire, 2 individual questionnaires. There's ever married women's questionnaire and never married questionnaire. And then survey, there was training conducted, which was two phases of training. The first one for the MR, more than 247 data collectors were trained, and 49 TOTs were trained for the MMR data collection. And for the main survey, 51 TOTs were trained, 347 data collectors also were trained, and 19 master TOTs also were trained. The data processing and report writing for this survey, it was 4 stages, as you can see, starting with developing the web CS Pro web server and developing the tabulation plan of the survey, tabulation plan for the recording manuals, and creating 5 different DHS standard files. And it's 2 editing manuals was developed, and followed by editing manual and imputation of the data, as well as development of the analysis syntax using SPSS software. And finally, production of the weights and verification of the unweights tables. In stage 3, weight was developed, and the tables with weighted was produced, and verification of the weight tables were conducted, followed by national data validation. In stage 4, it was report writing and review, as well as editing, design and layout, and presentation and web hosting, as we are attending right now. Let me start with the key findings, key indicators, starting with the household population and housing characteristics. The age structure of the population in the surveyed household is a typical of society with a young population. It's in line with the developing countries' population, where there is higher fertility and higher mortality rates among older age groups, which is demographically present a young population. The dependency age groups, 58% of the population were either young or elderly dependents, while the remaining 42% were working age group of age 15 to 64. For the girl and adult population, 62% of the population were below 18 years age, and only 38% were over 18 years and above. That's adult population, while adolescence stands at 26% of the population. The household with access to improved source of drinking water. Improved source of drinking water was considered as a bite water, protect deck wells, tube wells, boreholes, rainwater, and bottled water. We found that 65% of the households get their drinking water from improved water sources. It's slightly over 3/4, 76% of urban households have had access to improved water source, while just over half, 55% of the rural households have had access to improved water source. 34% of the nomadic have had access to improved water source. Coming to household sanitation, over half, 57% of the households have had access to improved toilet facilities. 22% use facilities they're considered non-improved, while the remaining 21% of the households have no access to sanitation facilities. Looking at the place of residence, households were varies greatly. A majority of the households in urban areas, 72% have had access to improved toilet facilities, followed by rural households at 49%, while only 1% of the nomadic households have had access to improved toilet facilities. Coming to the respondent characteristics. Education attainment and literacy for women aged 15 to 49. The percentage distribution of all women aged 15 to 49 by highest level of schooling completed. Overall, 75% of women have not attended any formal schooling. Only 25% of women have at least primary level of education. For the literacy, we found just about 72% of the Somali women aged 15 to 49 literate. Coming to the marriage, fertility, and its basic. Age at first married or childbearing commence is an important determinant of overall level of fertility as well as health and well-being of the mother and child. Percentage of first married by exact age for women aged 25 to 49. 16% were married by age 15, 33% were married by age 18, and 75% were married by age 25. The median age at first marriage among ever married age 25 to 49 is 20, which means by age 20, half of ever married women have married before age 21. The median age of first birth was also 21. That means by 21, half of ever married women age 25 to 49 have had their first child before age 22. Coming to the pregnancies and births by young married women 15 to 19. 40% have either given birth or were pregnant with their first child. Looking at the place of residence, nomadic was the highest at 19%, while urban was lowest at 11%. Coming to the fertility, start with the 8 specific fertility rates. The fertility here, the fertility rates here considered for the 3 years before the survey. The age-specific fertility rates in the 15 to 49 age groups peaks at age 20-24 and drops thereafter to 33 births per 1,000 women in age group 45 to 49. Age-specific fertility rates are lower in urban areas than in rural and nomadic areas in all age groups. Coming to the knowledge and use of contraceptive. Contraceptive is one of the most frequently used indicator for assessing the access of birth spacing programs. Is examining the current level of knowledge and use of contraceptive. It's also widely used as a measure in analysis of determinant of fertility. Percentage of currently married women have had any contraceptive method, either traditional or modern method. The knowledge of contraceptive is almost the same in both methods at 63% and 62% respectively. For contraceptive use, only 7% of the current married women were using any contraceptive method, and only 1% were using modern method. Thank you very much. Over to Felix.
Thank you very much, my colleague Abdinur. Your Excellencies, Honorable Minister, and other distinguished guests. I would like to continue with the remaining parts of the presentation, and I will ask my colleague Abdinur to help me to move through the slides. So I will start with the section on maternal health. We know that maternal health is a very, very critical aspect, especially with regard to the issues regarding the health of the mother. And that is critical in lowering the overall maternal mortality ratio. Okay, move to the next slide, please. No. Okay, I will begin with the uptake of the antenatal care clinics. And overall, the survey found out that 1 in 4 women have attended at least 4 ANC clinics during their last pregnancy. And overall, that 1% of them, of the women, have had some kind of ANC attendance from skilled provider. With regard to the components of the ANC, we have 9% of those who attended ANC had their blood pressure measured, 64% had the urine sample taken, while 68% of those who attended ANC clinics had their blood sample taken. With regard to taking the tetanus toxoid injections that will prevent them, the babies against neonatal tetanus, 17% had 2 or more injections, while 27% had their neonatal children, protected against neonatal tetanus. Next. Assistance during delivery is a critical component that directly impacts in the reduction of maternal mortalities. We know that if we have more women delivering in safe hands, we know that we reduce the chances of them getting problems when they're delivering. The survey found out that 32% of the births that were delivered were assisted by a healthcare provider, And of those, 21% were done in health facilities. And we have the highest attendance in urban areas, as we would expect, at that 4%, and 25% in rural areas. I think another word or important thing to note is that we have 57% of parts taking place under the assistance of the TPS, or traditional path attendance, rather. Okay, next slide, please. Okay, we are going to cover next, the child health is also a critical component that was covered by the survey, and we'll begin with the vaccination status of children aged 12 to 23 months. Overall, we see the vaccination status still very low at 11%, and the highest antigen is PCG at that 7%, followed by polio at 26%, measles at 23%, and penta at 12%. Next, please. Okay, with regard to the prevalence of early childhood illnesses, the survey covers 3 critical early childhood illnesses in the country, and this is acute respiratory infections, fever, and diarrhea. And the prevalence for the children in the last 2 weeks preceding the survey who had suffered either ARI, fever, or diarrhea is shown in the figure. As you can see, fever is highest at 7% of the children, followed by diarrhea at 5% of the children, and ARI at 4%. And with regard to health-seeking behavior, we find that children, majority of the children who are taken for treatment were those who suffered from the diarrhea at 48%, followed by fever at 6%, and ARI at 22%. Next. Okay, the next important topic we are going to discuss about is child nutrition. And under child nutrition, we have 2 critical indicators. One indicator, a set of indicators on breastfeeding status for children under 2 years, and then the second critical indicator on the important nutritional status indicators, that is standing, wasting, and underweight. With regard to breastfeeding, that 4% of children were exclusively breastfed under 6 months. We know that is critical. The WHO recommendations are that children should be breastfed exclusively without giving them even water in the first 6 months of their life, and this protects them against diseases and other complications. 90% of the children have ever been breastfed, and 60% of them started being breastfed within 1 hour of birth. We know that early initiation of breastfeeding of the child is critical also to the child's survival. 83% started breastfeeding within 1 day of birth. And we have those who continued breastfeeding after 1 year. This is 48% of children under 2 years. Next. 3 critical indicators for assessing the children's nutritional status. These are perhaps the most important related to the Sustainable Development Goals. Goal 2 wasting, standing, and underweight. As we all know, standing measures the long-term nutritional deprivation that happens as a result of either the child not getting proper feeding for a long time, or having some kind of illnesses for a long time. 28% of children are stunted, and we have the short-term malnutrition, which is acute undernutrition, which we call as wasting. 12% of the children are acutely malnourished, while 23% of them have acute weight loss, in other terms known as underweight. Next. Okay, the next slide talks about HIV knowledge and discriminatory attitudes of women. Just to let the audience know, the survey only covered the knowledge and attitudes part of HIV/AIDS coverage. The survey shows that we have a very low level of comprehensive knowledge of HIV/AIDS, despite the fact that some specific components that measure comprehensive knowledge, some of them we have a high percentage, such as 40% of women believe that a healthy looking person can have HIV/AIDS virus, followed by 38% who think that HIV/AIDS cannot be transmitted by supernatural means. Overall, we find out that the comprehensive knowledge of HIV/AIDS is very low at 6%, and we have very high discriminatory attitude towards women at 48%. Okay, next. Okay, another critical chapter that we'll discuss about is women's empowerment. We know that when women are empowered, their rights are also safeguarded. And we know that one of the ways that women can be empowered is by them being allowed to make critical decisions regarding the family. And one of the critical decisions is with regard to how their earnings can be used, or the earnings of the family could be used, or the resources of the family could be used. And we see the survey shows that 50% of the women decide themselves on how their earnings can be used or could be used, while 41% of them decide jointly with the husband, while another 10% of the cases it's mainly the husband who makes the choice. So overall, we see that Somali women are empowered with regard to the decision on the use of their earnings. Next. With regard to ownership of assets, and this we measured first by assessing the ownership of a house, ownership of a bank account, and ownership of mobile phone. And overall, that 5% of women own at least a house either alone, jointly, or both alone and jointly. And 3% own a bank account. Some interesting statistic is that 75% of women in households own mobile phones, and this can be critical in terms of communicating messages with regard to family health, the health of the children and the women. And also we find out that 64% of women use mobile phones for financial transactions. Next. With regard to gender-based violence, one of the key aspects that the survey measured is the physical violence. And this chart shows the experience of physical violence by women aged 15 to 49 since age 12. And overall, we find that 14% of the women admitted to have ever experienced some form of physical violence. And some of the common injuries are cuts and bruises at 26%, eye injuries, sprains and dislocations at 19%. And overall, that 5% of the women had at least, of the women who experienced violence had experienced some injury. 17% of those women sought some kind of help. Next. Next is female circumcision. We know that female circumcision is a common cultural practice in the country. And overall, the survey finds out that female circumcision rates, also known as female genital mutilation, is still very high at 99.8%. At 99.2%, sorry. And overall, one other interesting feature that we find out is that now there is less preference for the extreme forms of circumcision, which is pharaonic, and now there is a preference of the Sunni, which is the mild form of female circumcision. That is what the chart shows. Next. The survey also sought to find out the opinion of these women on whether circumcision should be continued and if it's a religious obligation. And 72% of the women aged 15 to 49 say that circumcision is required by religion, while another 76% feel that circumcision should be continued. Only 19% feel that circumcision should be stopped. Another 4% say it depends. Next. Okay, we know that chronic diseases and disability is something that is critical, especially at the time that we're experiencing a new wave of a new problem of COVID-19. And we know that these pockets of population are much more vulnerable to this problem than the normal population, these ones, and probably the elder population. With regard to prevalence of disability, overall 5% of persons in the household have some kind of disability, and the most common disability is sight disability, while the least common is learning disability. Next. With regard to prevalence of chronic complications, the most common chronic complication is blood pressure related ailments at that 3%, followed by diabetes affecting 20% of the population, and 8% suffering kidney diseases, while another 8% suffer arthritis. Overall, from that chart, we see that chronic disease prevalence increases with age, which is what we should expect. Okay, next. So finally, we are on the last slide, and the last slide talks about adult and maternal mortality, which are the two critical indicators in the population. I will start with maternal mortality, and we have three critical indicators of maternal mortality, which is a maternal mortality ratio, which is usually measured as deaths per 100,000 live births within the population, deaths of women per 100,000 live births. And the important thing to note is that for the measurement of maternal mortality, we usually consider maternal mortality as deaths occurring to women either during pregnancy or during birth and up to 6 weeks after birth, which is known as a puerperium period, where the women are still vulnerable to complications related to birth. Overall, we find that 692 maternal deaths are experienced for every 100,000 live births that occur in the country. With this, 1 in 1,000 women lose their lives because of pregnancy or birth-related complications. And how does this transition to the overall long-term, lifetime risk for these women? It shows that 1 in 20 women aged 15 today will die of pregnancy-related complications by the time they exceed the reproductive age. And that is quite high by all means, as we can see. The next, last and also important indicator that I would like to mention is the adult maternal mortality rate. With regard to adult mortality rate, we find that we have a slightly higher mortality rate among women compared to men, and this is a little bit worrying, given that in most populations we expect that we have more mortality among men compared to women. And this is directly related to maternal mortality related kind of deaths. So we have 7 deaths per 1,000 men for men, and 8 deaths per 1,000 women for the women population. And how is this in relation to the risk or probabilities of dying? We find out that also women have more probability of dying at 25% compared to men at 24%. And this is to mean that the men or women who have reached age 15 today are likely to die before they reach age 50. And this is 25% among women and 24% among men. I have come to the end of the presentation, so I'll hand over back to our organizer. Thank you very much. Matt Summit.
Thank you very much, Felix and the team, Mohammed Noor and the DG Abdurrahman, for sharing with us this very important and critical data for Somalia. Yes, let me just mention that the innovation here is that for the first time of such a survey with this magnitude, we've included the nomadics. Previously, a population domain that's not been captured once before. So the data that you've seen has the nomadics, which obviously give us the whole and accurate picture of the Somali situation. And also it is goes without saying that capacity building has been embedded in this project, that the data was collected by the Somali team, guided and led by the technical team at the UNFPA. So it has also been some of a novelty here, same as the previous survey of population estimation survey, to strengthen the statistical systems of Somalia. So now that we have the data presented and you have the information available and you've seen it, we are now opening the question and answer session, which will be led by Mariam Alwi, the team leader, the head of population development unit, who has worked tirelessly to make sure that this project is fully implemented, and also the documents are ready for today's launch. Also with her, we have Saeed Abdullahi Abdi, the head of Survey and Census Division of the Directorate of the National Statistics of Federal Government of Somalia, who also been a key technical personnel in the survey, as well as Felix Mulawa, our technical expert in leading the data collection and processing. So let us open the floor for any questions and comments so that we can proceed. We have, if I could forward, the first question that we have is that in terms of the FGM, did you ask the difference in opinion between severe and mild forms of female circumcision? That's the first question by Rima Abdullah, USA. Sorry, Dala, USA, yeah. Over to you, Tim.
In my opinion, with regard to the different forms of circumcision, we asked overall, what is the opinion? Do they feel that a female circumcision or female genital mutilation should be continued or should be stopped? And the other opinion question we asked is whether it is a religious obligation or not.
Thank you very much indeed. The second question that we have is when can we get the data for specific regions and zones? When can we get that, the specific data for regions and zones?
Thank you very much. That is a very valid point. The survey had two phases. The project document, the first phase was we were not even sure that we'd be able to achieve such a milestone today we are all celebrating, was to cover the national level, urban and rural and nomadic, and this will immediately be followed by state level reports, where within the state level reports, we are going to have the region, each region, so that they're also going to it will help them to formulate their own plans and policies, and this will be done along jointly with the Ministry of Planning and Health, the federal government of Somalia. Thank you.
Information available, is asking the neonatal mortality rate, child mortality, and under 5 mortalities.
Sorry, Osman, we didn't hear you. The mic was muted.
Good. All right. So we have another question by Muhammad Abdurrahman. He's asking, do we have any related information to neonatal mortality rates, child mortality rates, under 5 mortality rates?
The neonatal under 5 and child mortality rates, we know it's a critical indicator. Everyone is looking forward to it. It's one of the areas that is really critical under this survey. So we will have that one out very soon, inshallah. We are still working on that component because we needed to do a little bit of adjustments and what have you. And one of the major reasons is that when you're dealing with the data relating to the intervals between the parts and what have you, there is a lot of work that you need to do to make sure that it speaks to each other. So that's what we have been doing. So we will, inshallah, have it soon. But it's not part of this report that we are launching today.
By Humayun. We have another question by Humayun. A large proportion of the Somali population is nomadic, and from the findings, it's quite clear that almost all the indicators are very poor in the nomadic population. Is the Ministry of Health or Planning will develop a strategic document to address the health needs of the nomadic population?
I think that particular question I would like to hand over to the Ministry of Health and Planning.
May I invite the Minister?
Okay, maybe let me come in. This is Noor Ali, Director of Planning, Minister of Health, Federal Government of Somalia. Thanks to Humayun for raising this important bit of attention, particularly for the nomadic, because it has been underserved population. And this we are getting clearly shows that we don't have a clear response to it. So definitely it will be our top priority for using this information to our strategic and operational plans. So whatever information we are getting from this, it will be directly contributing to our upcoming policies and planning. So that is definitely, of course, in collaboration with our development partners. Thank you.
So thank you very much, Noor, the Director of Planning at the Ministry of Health, the Federal Government of Somalia. Thank you, and thank you, Humayun Rizwan, WHO, for raising this. We will continue with the Q&A session. Let me also invite another question by Johan Sang. Apologies if I have mispronounced your name. When will the microdata and technical documents be available to the public? When will the microdata technical documents be available to the public? Let me raise that the team with Mariam and Saeed and Felix.
And we have already started jointly with the Ministry of Planning, the Directorate of National Statistics, looking at how best are we going to allow accessibility to microdata, and all other related documents will be uploaded latest by today and tomorrow. The microdata will also be uploaded very soon. We are already looking at it and the options. So within, let's say in the next 2 weeks, you'll be having the micro library data uploaded and ready for use. Thank you.
Hello. Just I would like to add one comment. The Director of National Statistics, Minister of Planning, Investment and Economic Development has a micro library. As Mariam said, this report that we are launching today will be available within 2 weeks' time. And when the module for child mortality, neonatal mortality will added to the report, it will be also available. And also all the syntaxes and tabulation plans, all the manuals that were used will be available when that module was added, will added to the report. So everyone will be available, and everyone will access that macro library just by filling his information, basic information about his name, email address, etc. Thank you.
Thank you, Saeed, for that response. Again, Hassan Chama is asking the same question in terms of child mortality rate. He's saying that it's missing. So that was addressed earlier on, that this information, neonatal child and mortality rates will be available in due course. So let's pass that. Let me also then, there's another question by, again, Dr. Mohammed. He's asking that, sorry to come again, I hope to get this information. I was wondering if facility utilization rate was included under the health seeking behavior. Was it captured in the presentation? I missed it, he's saying. Felix.
Yes, I would say partly yes, because for most of the indicators, health facility access component was covered, and this is like for ANC coverage. If you go to the detailed report, there is an element showing the health facility component of it. Where did they go? They go to private facilities, to public facilities, or where, with regard to the child health, the same. So depending on which model we are looking at, we have shown that element as well. So that indirectly can help to assess the health facility access.
And also raising these questions, it's generating a very interesting, for us also to receive these questions. is an indication that it's generating interest. So we have another question, Rayan. She's asking, I was surprised to see the result of vaccination of the country. It's only 11%.
Okay, basically, to be honest, we were aware of it, and we took every effort to ensure that there is no mismatch in our data. We even had to engage experts to validate our information, and I think the low coverage is mainly because the high number of coverage for the nomadic areas, which was never the hard to reach area, which was never covered before. But when we found it, even ourselves, we were surprised. We went back, each one ran their own data to the extent that we had to involve even external experts to validate, and that is the reality we are getting. However, the Ministry of Planning, the Ministry of Health, the experts has a feeling if this survey has covered 3 components, that could be the realistic figure.
Continuing with the questions, Mariam from St. John's, Canada, she's asking, did you ask men about FGM?
The survey did not cover men. It only focused on the ever married women aged 15 to 49, never married women aged 15 to 49, and also for the children we took the measurements, the anthropometric measurements.
Another question by Folwell. Did you ask or collect about HIV and AIDS prevalence rate and family planning uptake rates? He's asking those 2 questions. Did we collect any information on HIV prevalence rate as well as family planning uptake rate?
Okay, with regard to prevalence, like I said when I was presenting that particular slide on HIV, I said we focused only on beliefs, attitudes, and knowledge. We did not cover the prevalence bit because of the sensitivity, the cultural sensitivity. With regard to family planning uptake, that is a contraceptive prevalence rate. Yes, we covered, and the contraceptive prevalence rates are very low. Uptake of modern contraception is at 1%. Modern plus traditional is at 7%. Thank you.
Thank you very much. We have another question by Patricia Schwessel. Apologies if I mispronounced your name, from the SHINE program. She's asking for from the trend analysis, can you assess in which areas major progress can be seen over the past years? Can you assess areas can you assess in which areas that major progress can be seen over the years in the light of this data? Can you tell, she's saying, the trend?
Okay, what I will say is that if you ask the Directorate of National Statistics, this survey for us is acting as a baseline survey for many reasons. One of the reasons being that many other surveys have not captured the nomadic component, and also with regard to the methodologies and approaches used, this particular survey was a bit different from other surveys. So we will consider this as a baseline survey and then monitor moving forward any changes that will happen. And then with regard to maybe regional differences, those ones you will see when we will be covering in the next phase of this exercise. We will be focusing on the state level reports, and in the state level reports you'll be able to see the regional and state level variations across indicators. Thank you.
Thank you very much indeed. We have another question by Mariam Sheikh. She's saying that this is in regards to FGM. The claim that we moved from severe to type 3 or to mild has been there for some time. She's also saying that my 70-year-old sister believes It started with high, yet we still have the reality is there. We have FGM prevalence rate, 99% of all efforts. With all these years, partners working in Somalia need to think about their strategies. What's the plan now? What do we need to do?
Okay, thank you very much, Mariam, for very valid question. We also thought the same, and we also had invited all the enumerators who are mainly midwives and doctors to also have the understanding and call for action. And I think there's also an article that has been published. This thing has been going on for almost over 100 years, yet there's little changes. So for them is to, like you clearly say, to look at actually to see who are the right audience for the people to deal with, to change the mindset of the people. However, we would say it's a big achievement to see that the Sunni is going up and the Pharaonic is going down. And also, let's also remember, like my colleague said, this is the first time forever we are covering a very large sample of the nomadic population that will have a direct impact to all the indicators. So you might end up hoping to get lower figure, especially on the FGM and or immunization, but you'll be disappointed because we are looking at it at a national level. Maybe later when you look at the state level and regional variation, you might then see why is this indicator behaving a different way from this state to compare to that state, or from this region compared to that region, and we will know, is it because of lack of health facility, lack of accessibility, and many other reasons. Thank you.
Thank you, Mariam, for that clear explanations in regards to FGM. We have another question by Ibrahim. He's asking, is this report for the whole Somali federal states or just part of the country? Yes, that's the whole. Let's move on to the next one. It covers the whole Somali federal states. The next one is from Ayaro. Can you please speak briefly about access to health-seeking behavior between male and female youth?
Yeah, like I said before, this survey mainly covered women of reproductive age. We did not have a covenant covering men. So because of that, we will only speak about women's access to health. And if you will, inshallah, get access to this report, you'll find that we have covered comprehensively the issues of access to healthcare with regard to various components of healthcare.
Thank you very much. Another question in regards to the immunization by Sandrine Chopin is asking, is the survey capturing penta immunization per region and districts?
Thank you very much. Our domain of estimation was the region, but definitely when you do a survey within a region, you cover district. So yes, it covers all the pre-war regions.
Thank you very much.
Yeah, maybe just to add on that, it covers all the pre-war regions, but in this report, you will not see regional level indicators, but in the state level specific reports you'll see.
Thank you very much. This is maybe a question for Saeed. He's asking, there are unreachable parts of the country. So how did you manage to get the right people and to collect the information? There are unreachable parts of the country. So how do you manage to get the right people?
I think we clearly mentioned it in the first chapter that we only cover 16 out of the 18 regions. That means we did not cover Mina Juba and Lower Shabelle. So they are not part of the analysis and the findings that you have just seen.
Said's question, we work closely with the Ministry of Planning and the Ministry of Health, and in each state we clearly know that we have ministries of federal member states, ministries of planning and health, and the enumerators were trained, who are mainly midwives and doctors. They were trained, the people we trained were from their respective regions and districts, because by the time we were doing the training, we had already sampled the areas we wanted to cover. So it made life easier because they were coming from their respective regions and districts. They were known, they took some drugs, so they were there not only to collect information, but also to support where the needed support is required. So that was why it made our life much more easier than where there's completely no access because of security reasons. We had to not to visit there because we didn't want to put people's life at a risk. That's why the coverage you saw, it was not 100%.
Okay, thank you very much indeed. These next two questions are quite related. Question is, under GBV, did the survey only capture physical violence? What about sexual violence and emotional? Asked by Mohammed Abdi, at the same time by Vincent Kutaya, is saying that has the survey captured sexual GBV?
Yes, it covered in the report. I think after the launch, as soon as after this session is over, you'll have it readily available through DNS and UNFPA website, so they can see the coverage. But also, Osman, for the sake of time, and we're seeing so many questions, I think we'll still like to answer them, but also we have to close the session, but they can still, when we launch the report, we have given them a web page where they'll still continue from the DNS website to ask questions, and we'll be more than happy to address them. Thank you very much. But before also handing over to you and closing the question and answers, I would like to take this opportunity to thank you all so much, to everybody, for the amazing words and all the work done. I just want to put this in 2001, when I was engaged by the World Bank and UNDP to roll out the socioeconomic survey, which is still in use. There was absolutely no capacity in the country. We faced so many challenges at all stages, to the extent that we had to hire experts from Kenya National Bureau of Statistics to train, to supervise, to analyze. But today, after a long time, I'm proud today to see with immense pride to acknowledge that to see the Somalia demographic survey driven, conducted from the inception to completion by the Somali federal government and its federal member states. I would like to take this opportunity to thank Minister Jamal and Minister Fawzia. Without their full support, standing by our side, this would not have been possible at all. So my plea to all is seeing the finding being used to improve the lives of the Somalis. Thank you so much, Osman. Over to you.
Thank you, Mariam, and the Q&A team for that interactive session that we've just concluded. And with those concluded remarks, indeed, this survey has been one of partnership. We're still promoting the partnership, working togetherness that we've achieved. The government and the UN, as well as the international partners, to be able to conclude the survey. And hopefully, what gets measured gets managed. So with that in mind, let me welcome Ambassador Gamal, the Minister for Planning, Investment and Economic Development, to officially conclude this session, and his remarks, so that we can also go ahead with the. Thank you. Welcome.
Thank you very much. Thank you very much indeed. This has been an eye-opening really important information. Thank you all. Thank you, Minister Fauzia and the entire Minister of Health team. Thank you, everybody, for your participation. Special thanks to the enumerators, people who went to the field and collected data both in the rural and urban areas. We cannot thank you enough. You have done a wonderful job, and without you, this wouldn't have happened. So thank you very much. Also, special thanks to entire Minister of Planning and Minister of Health staff for your dedication and commitment and partnership and team spirit. Thanks to UNFPA and the UN family as well for your support and guidance and all the technical assistance that you have provided during the survey. Special thanks to donors as well for your contribution and generous donations during this exercise. As we all see and agree, I think that this is a major milestone in our understanding, better understanding our society, our country, different parts of our people, especially the most vulnerable, women, youth, children, and elderly. And this is really a huge survey and covers a lot of ground. And it will help us better manage, plan, and program for the Somali people going forward. Thank you again for your participation. The full document will be available very soon on the Minister of Planning website. You can download it and we can share with you if you have your contacts. Definitely something that's worth reading. Been reading it and it's fascinating. You'll like it. Thank you again. Thank you very much and have a good day. Enjoy the rest of Ramadan if you're fasting. Otherwise, I will talk to you and see you very soon. Thank you so much. Take care.
Thank you very much indeed, Minister Gamal. Also, let me take the opportunity of thanking Honorable Minister Fauzia Speaker, who's also had her remarks, as well as the other key and very government officials and ambassadors, and also the donors. Just to highlight the donors' contribution was immense, and it was very much a gratitude by us to express our appreciation. So to express our appreciation to the Finnish government, as well as the British government, the Swedish, Italian government, and the Swiss agency for their support and endeavors that they've assisted this entire process up until to the end, up until the publishing of the data. And hopefully they will never be exhausted. We'll continue to make sure that this data gets used with the assistance of the government and other partners. We've had quite a number of people, like I saw on the screen there. We've had our key previous rep, Nikolai, who's there. I also saw Walter, our deputy for UNFPA, as well as Joanne McFadden and the entire team. So once again, thank you very much for all of you for coming, for the questions we compiled together. We will compile your questions and we'll have an interactive platform where we answer all those questions, and there will be other opportunities and alike. So thank you all, and thank you for listening, and thank you very much for the ministers. Thank you.
In 2018, the Somali federal government and member states took a large leap forward by undertaking a survey to find out more about the health and lives of Somali women and children. My name is Mikaltuma Ibrahim. I work with the UNFPA as a member of the Somali Health and Demographic Survey technical team. For the first time in the history of Somalia, a nationwide survey of this scale has been conducted. For the survey, more than 300 Somalis interviewed over 100,000 households across the country to ask questions about the health of women and children. More than 3/4 of these interviewers were women, almost all of whom had backgrounds in health. They walked through rough terrain with no roads, carrying with them scales to measure the weight and height of women and children. They climbed hills and braved the scorching Somali sun to interview a diverse representation of the population, the settled population and the nomads who had hardly been reached before.
waxaan lugeynay in la eg tusaale 3 kiiloomitir iyadoo ay jirtay qorax fara badan dabayl geedo aysan qof bini aadam u masaamixaynin inuu ku lugeeyo meeshaas haddana culays uu noo dheeraa oo ahayd inaan wadana miisaamo oon ugu talagalnay inaan ku cabirno dadka deegaanka markaanu u soconay waxay ahayd sidoo kale caqabad aad u fara badan.
Without these brave interviewers, this survey would not have been possible. The findings will result in a child or mother receiving better services in health, nutrition, or some other form that will improve their lives.